Good morning, and welcome to the Information Technology and Innovation Foundation's event on seizing the transformative opportunity of multi-cancer early detection, or MCED. I'm Stephen Ezel, Vice President of Global Innovation Policy at ITIF, and I'll be the moderator for today's event. As we get going, let me note that you may submit questions through the Slido application found at the bottom of the ITF event webpage, and we'll take questions in the last half hour of the event today. Just to quickly cover our run of show, I'll briefly introduce our eponymous report, which we released on Monday. We'll watch remarks provided by Senators Mike Crapo and Michael Bennett, then turn to our four esteemed guest speakers on today's panel and close with audience Q&A. I'll make formal introductions of our panelists, Jody Hoyos, Dr. Lynn Matresian, Dr. Josh Offman, and Anna Howard after my introductory presentation. Briefly about ITIF, we are the world's leading science and technology policy think tank. We cover a wide range of innovation policy issues across parts of the economy, from life sciences innovation to advanced manufacturing and clean energy. So, unfortunately, cancer remains an implacable enemy of humanity. Cancer is a leading second cause of death in the United States, claiming about 600,000 American lives each year. Cancer claims over 20 million lives globally. In fact, for individuals born today, 1 in 2 American women and 1 in 3 American men are expected to contract the disease at some point in their lifetimes. Fortunately, however, as ITIF writes in its new report, Seizing the Transformative Opportunity of Multi-Cancer Early Detection, a range of new technologies in the biotechnology and information technology space, such as genomics, advanced gene sequencing, artificial intelligence, and machine learning, are emerging that are enabling the development of entirely new cancer screening approaches. Specifically, multi-cancer early detection holds the potential to screen for many more cancers and detect them at much earlier stages. MCED technologies leverage the fact that all cells in the body shed nucleic acid, CFNA, nucleic acid fragments into their body. And MCED technologies look for circulating tumor ctDNA in the body as a biomarker, an indicator of a signal for cancer that can be detected. MCED technologies hold the potential to detect as many as 50 different types of cancers and even connect them to the tissue of origin in the body with a very low false positive rate and a high degree of confidence, as we'll hear more later from our colleague Josh Offman from Grail. But this really holds the potential over, say, the next 10 years to radically transform America's cancer screening paradigm. Today, only about 20% of cancers are screen detected. So in the vast majority of instances, patients are showing up at a clinic manifesting symptoms. These technologies give us the potential that in 10 years, we could flip that. And so 75% potentially of cancers could be screen detected in advance, perhaps half from MCED test, half from single cancer test, and then just about a quarter with symptom detection. It's vitally important to note, however, that MCED technologies are viewed as a complement and not a substitute to existing single cancer screening methods. But if we can get this right, as we'll see, it could deliver potentially significant economic benefits to society. Next slide. We need a revolutionary new approach because Azra Raza, who is a professor of medicine and director of the MDS Center for Comprehensive Cancer Care at Columbia University, notes, quote, "Cancer is still beating us." What this chart shows is that while the age-adjusted death rate per 100,000 citizens from heart disease fell by 2/3 in the United States from 1950 to 2010, the comparable rate for cancer just barely slightly decreased. Now, some have attributed this to the fact that kind of the heart disease research community has largely focused on early detection and prevention, whereas perhaps the oncology community has been more focused on curing advanced disease. As Raza puts it in the Wall Street Journal, quote, "We now invest a lot of effort in finding minimal residual cancer disease. Why not apply the same rigor and focus to finding minimal initial cancer disease?" In other words, we need better screening approaches. Next slide, please. Unfortunately, there are only 5 cancers for which there are Medicare-approved recommended screening guideline options today, those being breast, cervical, colorectal, prostate, and high-risk lung cancer, as we'll hear more from Jody Hoyos. This slide just briefly shows of the about 20 million fatalities in the world of 2017, the types of cancers they came from and which do not have screening options. The point here, obviously, is unfortunately very few cancers have screening options today. In fact, in the United States, 70% of all US cancer fatalities occur in cancers with no recommended screening options today. Next slide. So if we could truly transform America's cancer screening paradigm, we could generate substantial patient benefits, of course, by detecting many more cancers much earlier, which could really substantially improve patients' lives, because the reality is that when cancers are detected earlier, as we'll hear more from our fellow panelists, kind of survival rates are 5 to 10 times greater. There's a tremendous benefit from detecting cancers earlier. If we can do so, this may generate significant economic benefits. Today, cancer is the second most costly disease in the United States. Cancer care costs account for as much as 11% of US healthcare system expenditures. In 2017, that amounted to $177 billion, which was a 40% increase over the amount it cost in 2010, and that amounted to fully 1% of US GDP. Now, as you write in the report, citing studies from a number of hospitals and health maintenance organizations, the evidence is pretty clear that not only can we get better patient results when we detect cancers earlier, but treatment costs are less. In fact, treatment of metastatic cancer, once it has spread throughout the body, is on average about 2 times as costly as non-metastatic cancer treatments. And as the economists Murphy and Topol find, if we can really get this right, when we consider increased longevity, when we consider increased productivity and quality of life, that a 1% reduction in cancer mortality could deliver $500 billion in net present benefits to the US economy annually. And if we were able to find a cure ultimately, that could have a value of $50 trillion to the US economy. Next slide, please. Multi-cancer early detection screening can also deliver several ancillary types of benefits. First, beyond a simple blood draw, it's a less invasive screening procedure. It may also make it possible to detect cancers in the body earlier that are difficult to physically biopsy. Multi-cancer early detection technologies can also be helpful in reducing racial and socioeconomic disparities around cancer screening availability. It can be difficult for patients in remote or rural areas of the United States, for example, to see physicians or to access clinics or doctors' offices that have specialized equipment like LDCT, low-dose computerized tomography for lung cancer, mammography screening. So essentially, MCED could help make cancer screening options more readily available. And when you look at stats like breast cancer fatalities over a 10-year period are actually, you're likely to die twice as much in Mississippi than Massachusetts. It shows that across the nation, while there are a number of factors involved in disparities in cancer fatalities, some doing with health of the population, but a large part of it is, do we have access to the cancer screening options that we need? Are they available? Are we taking them up? Also, technologies like MCED over the long term could help address situations like the COVID-19 induced cancer screening gap we have today. With COVID-19, with patients concerned about going to clinics for exams, we've seen that just from March 15th to June 16th last year, there were 285,000 breast cancer exams missed in the United States. And aggregating this up, Dr. Ned Sharpless, a director of the National Cancer Institute, estimates that we may see as many as 10,000 additional fatalities over the next decade due to missed cancer screenings from this past year alone. So this shows the need for new innovations that can cover in the future perhaps these types of gaps in cancer screening and put us on the way to a more innovative long-term cancer screening paradigm. Next slide, please. Despite the incredible potential of multi-cancer early detection, some have raised potential misgivings about the technology, which the report addresses. First, with regard to cancers for which there are no or few therapeutic alternatives, and if we're able to screen for many more cancers, we may have cases where we're giving feedback to patients that you have a situation that there's not a cure for. This is certainly a concern, but we would point out, however, that first, patients have a right to know their situation no matter what, and it matters little whether that knowledge is delivered as a result of a biopsy or an MCED cancer screening test. But more to the point, as we hear from Dr. Limitation, for some cancers for which we don't have effective therapeutics today, part of the problem is that it's been difficult to identify patient populations at earlier stages of the disease against which innovative therapeutics could be developed and clinical trials run. So MCED technologies may help us identify these patient populations earlier, thus providing a platform for biomedical innovation against. Certainly, it's going to be imperative that these technologies limit the incidences of false positives and manage the trade-off between over and under diagnosis. Fortunately, however, it appears that the way the technology works is the more aggressive cancers in the body are more likely to shed this ctDNA, the circulating tumor DNA. And so the technologies appear that they're going to be able to be optimized more for the more aggressive cancers as opposed to the indolent type of cancers, the ones described as those that Americans will increasingly die with rather than from. It should also be noted that false positives are a challenge even today. So of the 9 million positive cancer notices delivered last year, it turns out that 8.8 million of those were false positives. So we have a false positive challenge regardless. Beyond this, it appears that MCED technologies have the ability to deliver at least comparable PPVs or positive predictive values compared to other single cancer screening tests today. PPV being if you've been told you have a cancer, do you indeed actually have it? So if we can achieve comparable rates, we can help manage that trade-off. However, overall, while avoiding overdiagnosis will be crucial to MCED success, we believe that the far greater challenge facing both American and global society is this massive underdiagnosis of cancers, as we've documented today. Next slide. Okay, in conclusion, what are some of the policy recommendations from the report? Well, first, it's important that as medical science's understanding of cancer has evolved over time, so too have recommended cancer screening guidelines. And today, with persons over 65 accounting for over 60% of newly discovered cancer malignancies and 70% of all cancer deaths, it's important that policy keep up with the technology. And therefore, we recommend that Congress pass the Medicare Multi-Cancer Early Detection Screening Coverage Act. This is legislation that allows the Center for Medicare and Medicaid Services, CMS, to cover multi-cancer early detection technologies once they've been approved by the Food and Drug Administrations. We'll hear more from Anna about this legislation. In the report, we also call for the Biden administration and Congress to increase NIH funding, including for the Cancer Moonshot. Funding for the National Institutes of Health in 2019 as a share of US GDP actually remained 12% below what it was in 2003. So we call in the forthcoming Endless Frontier Act and the American Innovation Act for increases in funding for NIH from the parts of the federal government. Lastly, the report includes a number of recommendations on how to increase America's biomedical STEM talent so we can continue to have innovation in both the field of cancer detection and cancer therapeutics. Next slide. With that, thank you. And we will now introduce our two senators. Idaho Senator Mike Crapo is the ranking member of the Senate Finance Committee, and he is a lead sponsor of the aforementioned Medicare Multi-Cancer Early Detection Screening Coverage Act, along with Senator Michael Bennett from Colorado, who also serves on the Finance Committee. I should also note that Representative Terry Sewell of Alabama had hoped to be with us to provide remarks this morning. She has led introduction of companion legislation in the House. With that, let us hear from Senator Mike Crapo. Thank you.
Hi, I'm U.S. Senator Mike Crapo, ranking member of the Senate Finance Committee. Thank you to the Information Technology and Innovation Foundation for inviting me to participate in this event. The event's title, Seizing the Transformative Opportunity of Multi-Cancer Early Detection, captures the significance of the topic. The title is also a succinct description of what led me to introduce a bill in the 116th Congress to provide Medicare coverage of these innovative, life-saving tests. Before discussing the legislative effort and the amazing work that makes a Medicare coverage bill necessary, my broader healthcare goals may provide insight. My healthcare focus as ranking member of the Finance Committee includes putting Medicare on a solid financial footing to ensure it can serve current and future beneficiaries, and updating Medicare's payment systems to foster innovation that improves patient care and program efficiency. The bill to provide a Medicare coverage for multi-cancer screening tests sits at the intersection of these priorities. That's why I'm so enthused about it. The expert panel assembled for this event, which represents great organizations, including my friends at Grail, can best cover the groundbreaking science and miraculous benefits. But these tests truly have the potential to revolutionize cancer care. Sadly, cancer claims over 600,000 Americans every year. It's amazing that a test can use simple blood samples to screen for dozens of deadly cancers. The ability to detect and treat cancers earlier will save lives. As seniors are at the highest cancer risk, it is imperative that Medicare pay for these innovative tests. Specifically, the bill would ensure that Medicare covers these vital screening tests without bureaucratic delay. It ensures that healthcare decisions are made by patients in consultation with their physician and are not dictated by out-of-date payment rules. Covering these tests will also be good for our healthcare system. There is no guarantee that the Congressional Budget Office will say the bill saves a lot of money, but it is clear that early intervention prevents more costly care down the road. Senator Bennett, along with Senators Tim Scott and Ben Cardin, have been great partners with me in this legislative effort. The House version of the bill has been introduced in the 117th Congress, and the Senate introduction will soon follow. My work to build support among my colleagues for the bill and to add co-sponsors will continue. The organizations participating in this event today, along with many others that make up the 300 strong that have endorsed the legislation, provide a tremendous boost to our efforts. This display of support, organized by the Prevent Cancer Foundation, includes a broad coalition of patient, provider, and biotechnology groups. Support from national and state organizations, including many in Idaho, is key to ensuring that policymaking keeps pace with science to best serve patients. Let us continue to work together to seize the opportunity to transform cancer detection and care. Thank you.
Hi, everyone. I'm Michael Bennett, and I represent Colorado in the U.S. Senate. Thank you to the Information Technology and Innovation Foundation for inviting me to kick off this important panel. If we learned anything from the last year, we have to invest in innovative tools to detect viruses, diseases, and cancer. I know from personal experience that early detection can make all the difference. As the second leading cause of death in the United States, cancer requires an all-hands-on-deck approach. People across our country, from our scientists to the biotech industry, are stepping up to develop innovative tools to detect multiple types of cancer early among asymptomatic patients. This will revolutionize our approach to cancer screening, save our healthcare system money, and most important, save countless lives. A cancer diagnosis delivers a devastating blow to a person and their loved ones. It not only takes a physical and emotional toll, but also a financial toll. It's no secret that our healthcare system works best for those who can afford it. The money in your bank account shouldn't determine the quality of treatment you receive. Early detection multi-cancer tools are a bright light in our efforts to care and treat cancer, but we need to make sure that our most vulnerable have access to those resources as well. And that's why I'm working with Senator Crapo of Idaho to pass a bill that would help cover the latest innovative tests for early detection through Medicare. I hope you can support our work in making this happen. and enjoy the discussion today. I hope we can continue the conversation in person someday soon. Thanks.
Well, thank you, Senators Crapo and Bennett, for those remarks. And let me remind our audience to submit those questions on our Slido application on the webpage. With that, let me introduce our panel. First today, we'll hear from Jody Hoyos, who is President and Chief Operating Officer of the Prevent Cancer Foundation, the only US-based nonprofit organization solely dedicated to cancer prevention and early detection. Prior to joining the foundation, she served as Vice President for the Association of Women's Health, Obstetric, and Neonatal Nurses. After Jody, we'll hear from Dr. Lynn Matrisian, who was the Chief Science Officer for the Pancreatic Cancer Action Network, or PanCAN. She is formerly a professor and the founding chair of the Department of Cancer Biology at Vanderbilt University, and she served as co-chair of the National Cancer Institute's, NCI's, Translational Research Working Group and a special assistant to the director of the NCI. After Dr. Matrisian, we'll hear from Dr. Josh Offman, who was the Chief Medical Officer and External Affairs at Grail, a pioneering company in the multi-cancer early detection field. Dr. Offman previously served as Senior Vice President for Global Health Policy at Amgen, and he also serves on the board of directors at Cell BT, a cancer immunotherapy company. Lastly, we'll hear from Anna Howard, who is Policy Principal, Access and Quality of Care with the American Cancer Association's Cancer Action Network, or ACS-CAN. Anna previously served as Medicare Reimbursement and Health Policy Director at Drinker, Biddle and Reith LLP, and before that, she served as a Medicare Advisory Manager with AARP. Thank you, panel, for being with us today. Jody, the floor is yours.
Wonderful. It's wonderful to be here, and I appreciate the Information Technology and Innovation Foundation for facilitating this discussion. It is tremendously exciting to be in a part of this period of innovation in cancer screening and early detection. The Prevent Cancer Foundation was founded 35 years ago with the sole focus of addressing cancer prevention and early detection to save lives. And 35 years later, we're still working hard. There's still a lot of progress to be made, and it's wonderful to have some exciting things to be thinking about. Next slide, please. So as Stephen mentioned in his presentation, we know early detection saves lives. We're focused on early detection as a foundation because we know how critical it is. The 5-year survival rate for cancers detected early is around 89%, and later stages that drops down to 21%. So the best chance we have at saving lives is through early detection of cancer. And right now we have 5 routine cancer screenings that are covered by Medicare, and that's breast, cervical, colorectal, prostate, and lung cancer. The impact to people is tremendous too. It is, based on 2020 data, 1 in 2 men and 1 in 3 women will develop invasive cancers in their lifetime, with 1 in 5 dying of cancer. And that's in the United States alone. And the United States has one of the highest cancer survival rates in the world. So this is really a true global burden. Next slide, please. Cancer screenings may also be available for oral cancer screening. You want to make sure you're getting your dental visits for your oral cancer screening, and skin cancer screenings. However, those may not be covered by insurance. Next slide, please. On the slide in front of you, you can see the estimated new cases by diagnosis in 2021, with the most prevalent diagnosis being breast cancer. So, and you can see some alignment with the types of screenings that we have now for the most common cancers diagnosed, as you would expect. Next slide, please. But the cancers diagnosed do not represent all of the cancers causing death. So there are hundreds of cancer types, which means that for the vast majority of cancer types, there is no screening available. Cancer deaths, cancer deaths without a screening account for 3 out of every 4 deaths in the United States each year. Again, 3 out of every 4 deaths by cancer each year are from a cancer that has no available screening. And you'll see that lung cancer is the #1 cancer killer for both men and women in the United States. Next slide, please. Okay, so what happens when we have a cancer screening available and that screening is covered by insurance? Everyone is getting it, right? No, unfortunately, that is not the case. The uptake rates for cancer screenings are not where we would like them to be. And there are many reasons for that. Some of the most prevalent barriers are lack of provider recommendation. It's critically important that a provider lets their patient know that they should be getting a cancer screening. Absence of symptoms. Ideally, cancers would be detected early before someone is symptomatic. But often a symptom or not feeling well is what prompts people to go in and get an appointment. Fear. So fear can be of the test itself, or now we have COVID exposure on top of that. I think we just skipped a slide ahead here. There we go. So fear of contracting COVID is now cited as one of the top reasons people are missing their routine appointments. That was found in a Prevent Cancer survey done in May, and then again repeated in December. Mistrust of providers of the system, access to appointments, and that can include transportation barriers, so people being able to get to appointment and having a facility that's located near you. Language barriers, cost, and awareness. Next slide, please. On the awareness front, the Prevent Cancer Foundation did a survey in December of 2020, and 1/3 of respondents stated that they were not sure what cancer screenings they should be getting. That's a pretty significant number, especially given the amount of information and education that we think is being put out there. The reality is it is very difficult to cut through the noise, and it's complicated. Even for those of us who spend all day looking at cancer screening information, keeping track of guidelines and what's changed and what you need to be doing is not a small task, particularly as you get older and the number of cancer screenings and medical appointments you have increases. Right now, about 2/3 of men and women are up to date with their colon cancer screening. And for lung cancer, which is the cancer screening with the lowest uptake, less than 6% of the eligible population is receiving lung cancer screening. And if you remember from my earlier slide, lung cancer is the #1 cancer killer. So that is concerning with where we are now. And I will say that these data are all prior to the pandemic. As Stephen mentioned, the COVID has had a tremendous negative impact on cancer screening rates, routine medical appointments, and interestingly, vaccination. So the human papillomavirus vaccine for children is being missed now. So parents are not feeling comfortable or have not taken their children in to get their HPV vaccines. And we know the HPV vaccine can prevent up to 6 different types of cancer. So the downstream impact of what has happened over the last 13 months is significant. Next slide, please. For medically underserved communities, and that includes communities of color and those people living in rural areas, the situation is even more pronounced. So the barriers are more significant. Screening rates are lower and mortality rates are higher. So it's really important that if we're going to address unmet needs in cancer screening, that we consider the needs of all populations in order to make a difference. Next slide, please. So a potential solution to the challenges we're seeing is one test that can test for many different types of cancers, including cancers for which we do not have a current screening. Those tests, multi-cancer early detection tests could be more accessible to people if they're available in more prevalent areas, more routine settings, so that you're reducing some of the access barriers. They wouldn't replace the need for the current single organ cancer screenings we have now. So there would still be a need for both tests, but if done with a patient-centered approach, and if there's coverage for these tests, there is the potential to detect many more types of cancers earlier and save lives. And next slide, please. And my contact information is here. If anyone would like to reach out directly, please feel free to do that. And now I would like to turn the presentation over to Dr. Lynn Matrizian.
Thank you, Jody. Ruth Bader Ginsburg, Alex Trebek, Aretha Franklin, John Lewis, and most recently, Representative Hastings, all people we've lost to pancreatic cancer. The American Cancer Society estimates that there'll be 60,000 new cases of pancreatic cancer this year in the United States. That's about 11th in terms of incidence. And there'll be 48,000 deaths. That's third in the number of deaths from cancer in the United States. This is a very deadly disease. Next slide. Survival is measured in months instead of years, and the 5-year survival rate for pancreatic cancer is just 10%. Now, we've made some progress over the last decade or so, so we're finally in double digits for survival rates. But progress has been extremely slow. And one of the main reasons, what makes pancreatic cancer so difficult? Next slide. And one of the main reasons is because it's detected so late. The pancreas is an organ that's buried deep in your body. And the symptoms that send somebody to the doctor are very vague and quite common. Things like backache and indigestion, the type of things that will take a while to figure out the cause of those symptoms. In addition, pancreatic cancer metastasizes very early. So even when the tumor is quite small, those tumor cells have evolved to obtain the ability to disseminate and colonize distant parts of the body. Next, please. And because of this, only 15% of people are diagnosed early enough that they're eligible for surgery. Surgery is our best treatment, our really hope for cure for cancers in general, and in particular for pancreatic cancer. And yet only 15% of people who appear in the doctor's office and get a diagnosis of pancreatic cancer will hear that surgery is an option. For others, it is either already disseminated in almost 50% of the cases, and chemotherapy is our only option for treatment of those cancers. It has to be a systemic therapy that will treat all of the cancer cells throughout that have disseminated throughout the body. Or it's localized to the pancreas or that area, but it is too close to major blood vessels to be surgically removed. So that's the situation that faces someone facing a pancreatic cancer diagnosis. Next slide, please. So early detection is our best bet in pancreatic cancer. If we can find it when it's localized, the 5-year relative survival rate jumps by more than 10 times to 40% of those individuals will be alive 5 years from now. If it's already disseminated, that's a 3% 5-year survival rate. And in a subset analysis that was done not too long ago, if you can find pancreatic cancer at stage 1A, the very earliest stage of cancer, that survival rate reaches what we would want it to be. North of 80% of those individuals will be alive in 5 years. So early detection is exactly what we need in a deadly disease like pancreatic cancer. Next slide. So why don't we have an early detection test for pancreatic cancer? Why is it not on those lists of early detection protocols for cancer? And it's not from lack of trying. If you go back in the literature, you can find publications on pancreatic cancer early detection as early as the mid-1940s. The number of publications, the interest in this area has increased over time, in particular in the last decade. And this is all very exciting. It's all very good. It's what we want to find an early detection method. But in all those publications, what they're looking for is biomarkers, so proteins, lipids, nucleic acids found in blood, in urine, in other biological fluids, and they're found in pancreatic cancer, but not in normal controls or individuals without pancreatic cancer. And virtually all of these tests have gotten caught at the stage where that's about all they can show, that they can show that there is a biomarker that's elevated in somebody that's already diagnosed with pancreatic cancer versus someone who does not have the disease. What we need to know is whether that test is effective at finding pancreatic cancer early. Next slide, please. So the challenge and the bottleneck for all this research for the last decades has been the incidence of pancreatic cancer. So the incidence is 13.1 pancreatic cancer cases in 100,000 Americans. And that means you have to screen 10,000 people to find one case. So that's a challenge for validation of those biomarkers, those things that we think might be a way of identifying pancreatic cancer early, because you'll have to set up a test, a study, in order to you'll have to have 10,000 people in that screen to find one case of pancreatic cancer, and that's simply not feasible. It's also a challenge for implementation. How do you then roll that test out to the American public when you have to screen 10,000 people to find one case? So in the pancreatic cancer field, what's been done, next slide please, is to try to decrease that 100,000 number, to try to say, can I screen just 100 people to find one case instead of 10,000 people to find one case? And we've been looking at that by looking then at high-risk individuals who either because of their age, perhaps, because of their genetic predisposition, they have a gene that's inherited that gives them a predisposition to pancreatic cancer, or in some cases, new onset diabetes is a very early symptom of pancreatic cancer, which elevates a 3-year risk of pancreatic cancer to around 1%. So it's a combination of these factors that scientists have been looking at over the last number of years to try to be able to validate and identify a early detection test for pancreatic cancer. But there's another way of doing this. Next slide, please. And that's the multi-cancer early detection test. And it's a very clever way of looking at this problem with a different lens. And it's saying, okay, instead of altering the number of individuals we have to screen, what if we increase the number of cases of cancer that we could find in that population? So that is adding that incidence of pancreatic cancer to the incidence of other cancer types to get you to a place where, again, you could screen around something, and these are just example numbers, but screen 10,000 people to find 100 cases, something that's much more feasible for both the validation of that test and for the implementation of that test. Now, the cancers I chose on this slide, next slide please, represent the deadliest or the recalcitrant cancers. And those are the cancers that are defined as those with a 5-year relative survival rate of less than 50%. And it is these cancers where we will make having an early detection test can really make a very significant impact on on survival for those individuals. Finding those cancers early are where we have much better survival rates than finding it very late. Next slide, please. So I am very encouraged, optimistic, excited about multi-cancer early detection tests, and in general, these advances in thinking about early detection of cancer. I'm hoping that soon I will be able to say to Matt Wilson, who was fortunate enough to have his pancreatic cancer found very early as an incidental finding on an abdominal scan that he had for another reason. But he's been dreaming for 9 years now of the day when a pancreatic cancer patient is diagnosed early. And it's not lucky, but it's bringing science, bringing an early detection tool to this problem. So it's really exciting to be here today and to be talking about transformative ways of looking for cancer early detection. And with that, I will turn over the microphone to Dr. Josh Offman of GRAIL, who will tell us more about their approach to multi-cancer early detection.
Thank you, Lynn. Go ahead and advance the slide, please. So I'm thrilled to be here to be able to talk to you all today about one approach to multi-cancer early detection from GRAIL, a company really dedicated to developing innovative transformational technology to change the way that we think about detecting cancer early when cancers can often be cured. Next slide. So the reason we're focused on this issue is very well illustrated on this slide. You know, most of us have experienced or been touched by cancer in loved ones, in our own family, in ourselves. And it's one of those dreaded diagnoses. And that's because most cancers are detected too late when outcomes are very poor. You know, if you detect cancer, as Dr. Matrizian just said, in its localized state, about 9 out of 10 patients will live 5 years. And this is across all cancers. And when you diagnose it after it has metastasized already to distant sites, only about 2 of 10 people will live 10 years. So it's just an enormous opportunity to change mortality and survival if you can detect cancer early. And unfortunately, while we do a really good job in this country screening for 4 or 5 single cancers, most of the cancer deaths are occurring in cancers with no recommended screening at all. And so this is the challenge before us that we think new technology using genomic sciences can help us address. Next slide. And what's so interesting about multi-cancer early detection, one of the real promising aspects of it, is that when we show up for single cancer screening, you know, we're taking that healthcare challenge into our own hands. We're going and looking for breast cancer or colon cancer, cervical cancer, prostate cancer, lung cancer. But what we fail to remember is that even while we're looking for those single cancers, we are much more likely to be diagnosed with some other cancer than the one that we're looking for. So that is one of the real challenges. In fact, for colorectal cancer, any individual who has completed their screening for colon cancer is up to 10 times more likely to be diagnosed with a non-colon cancer in that same year. So this is really the power of multi-cancer early detection, to try to find the cancers in individuals rather than looking for individual cancers. Next slide. And the reason we're here and we're able to talk about this today is really because of some trends in innovative technology. Over the last 2 decades, we have seen an explosion in technological innovation around genomic medicine and personalized medicine. And when you couple that with the improvements and the dramatic changes we've seen in machine learning and artificial intelligence, It's really the convergence of these technologies, along with the dramatic reduction in the costs of sequencing DNA, that allow us to sit here today, even talking about genomic technology coupled with machine learning and AI that can now detect over 50 types of cancers with a single blood draw. Next slide. So GRAIL's approach is really based on the recognition that when tumors are growing in individuals' bodies, the cells are dying and they're shedding little bits of DNA into the blood. And most work done in the blood looking at DNA has been focused on people already diagnosed with cancer. And they're looking for very specific mutations and trying to figure out whether that cancer has a certain type of treatment or has recurred. So when you move to early detection of cancer in patients without cancer, you have to think very carefully about how to interrogate the DNA that's circulating in the blood. And GRAIL, to its credit, did the largest R&D study here comparing the different ways of looking at the DNA. And they asked the fundamental question: should we look at mutations? Should we look at chromosome changes? Or should we look at methylation changes, which are epigenetic changes? These are molecules that attach to the DNA and turn genes on and off, but they don't change the code of the DNA. So they're very different from mutations, but they're a very powerful signal because there are so many of these methylation markers across the genome. So they compared these head-to-head and learned that DNA methylation patterns were far and away the most powerful way to detect early cancer and to localize those cancers to very specific tissues and organs. And so GRAIL moved forward with that method to develop its assay, which is now fully validated. Next slide. And here are the results of the latest validation study. And I'm not going to go through this in detail. I'll highlight a couple important findings. First, with a single blood test, the assay was able to detect over 50 different types of cancer, which really changes the paradigm for how we think about cancer detection and screening. Currently, we only screen for one cancer at a time, one organ at a time, and we only look for 4 or 5 different cancers. The most important performance metric is what we call positive predictive value, which means among those with a positive test, how likely are you to have cancer? And our test showed that that was 44%. Just to put that in context, for mammography, it's about 5%. For low-dose CT of the lungs for lung cancer screening, it's about 4 to 5%. And for stool-based colorectal cancer testing, it's about 6%. So this is an order of magnitude different in terms of positive predictive value. And that's because we've been able to develop the assay with an incredibly low false positive rate, about 0.5%. And that's one of the biggest safety measures associated with this assay, because the harms of screening are often associated with these high rates of false positives. And in terms of detection, the test was really able to detect most of the high mortality cancers, as Dr. Matrician laid them out. And when you open the aperture to look for all 50 cancers, we were able to detect in early stages over 40% of them. And remember, most of them are not screened for at all. So the comparative sensitivity for those would be 0. And then when there was cancer, we were able to correctly predict the origin or where in the body the cancer was almost 90% of the time. So this is a very important assessment and study, because multi-cancer early detection holds incredible promise, but we need to move forward with well-validated and rigorously developed assays. Next slide, please. So the goal of Gallery, which is GRAIL's multi-cancer early detection test, is really a single blood test that can detect most cancers. It will complement, not replace, our recommended single cancer screening tests. And I'll talk about that more in a moment. The goal here is not to optimize detection of any single cancer, but to find as much cancer in the population as possible. And that includes including in your assay cancers that are difficult to detect. because they don't shed a lot of DNA into the blood. But by detecting any of them, we are increasing the amount of cancer we're finding in the population. And as long as this can be done while minimizing harms, keeping a very low false positive rate and focusing on detecting the cancers that matter, the ones that need treatment, we can minimize harms. So from a public health perspective, and this is in fact a public health test, these are the objectives, these are the goals, which are very different than single cancer screening tests. Next slide. And this is why this idea is so important. When I joined GRAIL, I asked a very simple question that apparently had not been answered before, which was, in the elevated risk population of adults in this country between the ages of 50 and 80, there's about 1.3 million cancers every year that we find. How are we doing in finding those cancers? And the answer here is in the third gold bar. When you look at the 5 recommended single cancer screening tests, which by the way are amazing and have been shown to save lives, because of their performance, because of their compliance, when you add them all up together, we are only finding about 16% of those incident cancers. And I think most of you would agree that's insufficient if our hope is to really bend the mortality curve in cancer. If you look at the far right bar, if we were then to add the Gallery test, which is GRAIL's multi-cancer early detection test, and everybody took it, we could now find up to half of those incident cancers. I mean, that's just a dramatic improvement in the cancer detection rate in the population. And then if we further ask, well, what about how do we do finding those high mortality cancers, as Dr. Matrician said, with 50% or greater 5-year mortality? Well, then we could find 3/4 of all of these cancers. So it's just a dramatic paradigm change in how we can detect cancer in the population, which many believe is the best approach that we could take to bend the cancer mortality curve. Next slide. And, you know, in terms of the economics of all this, it's clearly going to be a very cost-effective intervention to detect over 50 cancer types with a single blood draw, about as cost-effective as any of the single cancer screening tests. But what about the actual spending and the cost? So what we do know is that the cost, if you implemented a multi-cancer early detection test, the cost to find cancer drops dramatically, because now we're able to find so many more cancers at early stages and with many fewer false positives. But also the costs of treatment are very different in the early stages compared to the later stages. And that's illustrated on this slide. And I think it was mentioned in the introduction that treating metastatic cancer versus localized cancer can be up at least 2 times more, and often even higher than that. So there's great economic rationale also for finding cancer early, in addition to obviously the potential for life extension. Next slide. So we developed a very robust epidemiological model, which now has been published, that basically asked the question, what would the world look like if we introduced such a multi-cancer early detection test in the population? On the left side of the slide, in the gray bars, is how cancer is detected today. Too often in the late stage, when it's already widely metastatic and incurable and, you know, very difficult to treat. By introducing Gallery, we estimate that we could intercept about 70% of these cancers at an earlier stage and actually really change the distribution of stage at diagnosis. And this, if this were to happen, what impact would that happen? Would that have on mortality? And that's what's seen here in the right panel. And we estimate that we could detect about half of cancers at an earlier stage, and that could result in about a 39% reduction in the death rate of those expected to die in the next 5 years. That's about averting 100,000 deaths a year. And just to put that number in context, that's about what the American Cancer Society has estimated we're achieving in cancer today with everything we are doing for cancer. diagnosis, treatment, surgery, radiation, medicines, everything. So we have an enormous opportunity before us to ensure that this innovative technology that many companies are working on now, but GRAIL has now validated, has access particularly to populations like the Medicare population who are at higher risk of cancer. And we have an enormous opportunity to use this as a public health test to dramatically impact public health by bending the mortality curve for cancer. That's the opportunity that sits before us, and I look forward to the question and answer session. So thank you very much, and I'm going to now turn it over to Anna Howard from the American Cancer Society.
Thank you, Dr. Offman. My name is Anna Schwamlein-Howard. I'm a policy principal focusing on access to care issues for the American Cancer Society Cancer Action Network. ACS-CAN is the nonprofit, nonpartisan advocacy affiliate of the American Cancer Society. Next slide. So here is just a quick overview of what I'm going to talk about this morning. I'm going to talk about the importance of cancer screenings, which all other panelists have noted. Briefly talk about Medicare's existing coverage of cancer screenings, and then I'll talk about the Multi-Cancer Early Detection Screening Coverage Act, why it's needed, what it does, and its impact on existing cancer screenings. So next slide. So we know from research by the American Cancer Society that screenings can help detect cancers early when treatment is less invasive and yields a more successful outcome. And again, all other panelists had talked about this previously, but just to underscore that detecting cancer early leads to a better quality of life, leads to more outcomes, leads to a higher probability of successful treatment. So this is particularly important for the Medicare population because we know that the incidence of cancer increases with age, and most people qualify for Medicare when they turn 65. Next slide, please. So, as noted earlier, Medicare provides coverage of certain cancer screening tests. In some cases, Congress actually passed legislation and mandated coverage of specific cancer screening tests, and this goes back to the late 1980s. But Congress has also provided the Secretary of HHS, which has jurisdiction over CMS, which has jurisdiction over the Medicare program, the authority to cover additional preventive services if the Secretary determines that the services are reasonably necessary, if they're recommended by the United States Preventive Service Task Force, and if they're appropriate for Medicare beneficiaries. So next slide. So let's talk about the Multi-Cancer Early Detection Screening Coverage Act, which has been introduced in the House, H.R. 1946. This bipartisan legislation will provide a pathway at CMS for the approval of new multi-cancer screening tests. So why is the legislation needed? We know that science on cancer screenings and detection is moving quickly. We know that there are new and exciting things being developed all the time, and we want Medicare beneficiaries to be able to take advantage of this new technology. Unfortunately, just because a technology or service exists doesn't mean that Medicare will ultimately cover it. The Medicare program only covers items and services pursuant to its statutory authority that has been granted by Congress over the decades. So when Congress has given Medicare direct authority to cover something, then CMS moves through a process called the National Coverage Determination Process, whereby CMS determines its parameters for coverage. So next slide, please. So what does the legislation actually dictate? Under the legislation, Medicare is provided a pathway to cover multi-cancer early detection screening tests. The legislation tells the Medicare program, you can cover these tests. It doesn't say that Medicare has to cover all of tests. It doesn't say that Medicare can only cover certain tests. It's not Congress dictating the science. That's not their job. It just says to the Medicare program, if there was a question as to whether or not you have the authority to cover these tests, rest assured you have the authority. Medicare will decide, again, through the national coverage determination process, its specific parameters for coverage. Medicare will review the research and the science and will set the rules for coverage. This process allows for public comments. So stakeholders, all stakeholders will be able to comment on the coverage parameters that CMS proposes. And Medicare can also use this process to decide that it doesn't want to cover a specific test. Again, it's a flexibility that CMS is afforded so they can take a look at the current science and the current need and decide what is best for the Medicare program. It's also, the legislation makes clear that coverage and availability of multi-cancer early detection screening tests in no way, shape, or form changes Medicare coverage of other cancer screenings. So next slide, please. So the legislation, under the legislation, a multi-cancer early detection screening test will be covered if it meets these criteria. First, the test has to be approved or cleared by the FDA. That makes sense. The FDA requires rigorous scientific standards, and we want these tests to meet those standards. Next, it has to be a test that is approved or cleared to detect many types of cancer. It's pretty simple. If you're going to call something a multi-cancer screening test, then the test actually has to detect many types of cancer. The legislation just uses the word many. It doesn't dictate how many cancer tests constitutes many. That's left up to CMS. Again, it's another example of the flexibility that's afforded to CMS and that they would use through the MCED process to decide the coverage parameters. And the legislation also makes clear that it's only referring to specific types of tests. So these are tests that would be using a blood or a blood product, and blood products can be things like plasma, which isn't technically blood. It also, again, affords the secretary the flexibility to use an equivalent test. It could be urine or some other type of biological material. Again, it's a additional flexibility. It's not Congress dictating the science. It's basically saying to the secretary, look, in the future, it may be possible that other biological material has been shown to detect cancers, and you have the flexibility to approve those tests if you so determine. And finally, the legislation also states that coverage of these tests is only once a year. Next slide, please. And one thing that was really important to us was to make sure that while multi-cancer screening tests hold great promise, we in no way, shape, or form want to interfere with a beneficiary's ability to be able to access the cancer screening tests that are currently covered under Medicare. Again, it may be that a beneficiary and her doctor decides that a multi-cancer screening test is the best course of treatment. Great, we have a pathway for coverage. It may be that a beneficiary and her doctor decide that the best course of treatment for a beneficiary is both a multi-cancer screening test and the ability to take advantage of the existing screening tests that are available. Great. Again, these are decisions that the beneficiary and their doctor should be making, and we want to make sure that the multi-cancer screening tests provide an additional benefit option and don't supplant the existing screening benefits. Next slide. So thank you. Here's my contact information in case you have any questions. And with that, I will turn it back to Stephen.
Well, thank you, Jody, Lynn, Josh, and Anna for those fantastic presentations. So a reminder to our audience, we welcome your questions through the Slido application. And we've already received a few of them, which we'll start to go through now. First, so over the past several decades, despite the difficulties, we have been able to make some tremendous breakthroughs in both cancer screening with mammography, with low-dose computerized tomography for high-risk lung cancer patients, as well as with cancer therapeutics with things like cancer immunotherapy, checkpoint blockading, et cetera. In your own words, can you all kind of contextualize what you see as the potential magnitude of the opportunity for us we have now with multi-cancer early detection? How does it rank up with these breakthroughs in the past? And that's open to anyone who would like to jump in.
Well, I can.
Oh, go ahead.
Go ahead. I mean, I'll just say it really changes the way you think about. We've been so focused on individual cancer types. Which one should we worry about? Which one are we at most risk for? When's it, which screenings are available? That type of thing. I really think opening it up to think about cancer in general is a real shift in mindset in terms of how we think about this whole problem. It's really a major change.
Yeah, I'll jump in as well. I mean, the advances you're referring to, Stephen, in single cancer screening have been really important. And our single cancer screening tests have done an amazing job and have been demonstrated largely to improve cancer-specific survival. And so, the opportunity that sits before us, though, is to change the whole paradigm, because right now we know that those single cancer screenings, while wonderful, are not finding enough cancer in the population. They're not, and we're not able to single cancer screen our way out of this problem. It will never be cost effective to screen for these less common individual cancers. So what we have the opportunity to do is shift the paradigm from not only screening for individual cancers, but in addition to that, screening individuals for cancer. We don't get to choose the cancer that we get. So only looking for those 4 or 5 cancers may not serve me as an individual well. I want technology that can look at any cancers that I may have and be able to detect them early if possible. And we need to think of it like a public health test, very similar to the debate that just happened with COVID. How do we transition from finding that perfect COVID test and instead finding those COVID tests that can dramatically improve COVID detection in the population? And very similarly with cancer. It's about to become the #1 killer of men and women worldwide, and we are in a public health crisis with cancer detection. And the best way of getting out of that is to find cancer early when it can be cured.
And just to add on to that, I think that, we know that having access to health insurance and having access to coverage really is a barrier. And so what we want to do is we want to eliminate that first barrier going forward. We have, a lot of new technologies and scientific discovery, and that is great and wonderful. And since we know that coverage can be a barrier, the first step that is being done, particularly under this legislation, is to say, look, we are going to eliminate that barrier. We are going to say that we have a pathway for coverage so that we don't delay beneficiaries having access to these new screenings when they are appropriate. That legislation, as we all know, takes Congress a long time to enact legislation. And so we want to make sure that the first barrier is eliminated and that we can make sure that beneficiaries have access sooner when it's appropriate for them.
Yeah, and I'll just add there that after that first barrier is knocked down, the looking at a multi-cancer early detection test to address some of the other barriers that we talked about today has really significant potential. This is a complicated ask of people to track all their individual, their body parts by potential cancer types. And so if we can simplify the messaging that we're putting out to people across all populations, including medically underserved, I think that there's dramatic potential impact.
And Stephen, Jody brings up an important point that hasn't been touched on yet, which is, we've learned through COVID and many other cancer screening efforts that underserved communities often are doing the worst as it relates to attending screenings, getting their screenings, having access to screenings. So rural communities versus urban, underserved versus well-served, underinsured and uninsured. It's a big issue, and novel technology that can find cancer signals in the blood now provide a different opportunity to get to these underserved communities with a very simple blood draw rather than a complex procedure, imaging tests, or invasive procedures to find cancer.
That's an excellent point. As I was doing my research for this paper, one of the most shocking stats was from Dr. Otis Browley, who's a professor of oncology at Johns Hopkins University. Yeah, and he said for a woman diagnosed with breast cancer, the fatality rate is half in Massachusetts what it is in Mississippi, and there was quite clear disparities in the uptake of screening tests for both mammography and prostate exams between those two states. So that raises maybe another question we haven't touched on yet. As with any new technology across any field or any setting, training the users of that technology is going to become a critical consideration in terms of its adoption. Physicians play an essential role in ensuring that patients are adhering to screenings. What are some lessons we can learn from existing cancer screenings that can be applied in the multi-cancer early detection world to ensure that patients can fully benefit from these technologies once they're available? What will we need to do to educate the physician community across the US about the availability of these types of screening tests once they're FDA approved?
I'll start, and others I'm sure will jump in. I think the first thing, of course, is education. And I think it's important, certainly important, to educate the physician community, letting them know what the research on the specific tests are, what the tests can do and what they can't do. And that's very important. I think the other thing, and this often gets left, and it's unfortunate, is we need to also educate beneficiaries as well. That we need to make sure that people understand what these tests are, they understand the availability of these tests once the technology is available. And it's through the education that we will help people to understand kind of how to reduce their cancer risk, overall, that the availability of these tests just, can also help to supplant some of the other, or help to serve as an addition to some of the other work that's being done to help people minimize their cancer risk.
Yeah, I'll just mention, Stephen, in addition, educating clinicians is going to be critically important. We know from our experience utilizing our technology Gallery in a clinical setting that the satisfaction by providers and their patients is very high when they're properly educated about the test before it's given and before it's taken, and that's a very important predictor of that. Luckily, most physicians, when cancer signals are detected in very particular organs, our technology, for example, tells you if a cancer signal is detected, where in the body that signal is predicted to come from, pancreas or liver. And most primary care physicians and other doctors know how to look for that. Guidelines have been written for a long time, and there's very clear guidance about how to go after those cancers. So there's still some education to do about those unusual cases and difficult ones that are less common, but doctors seem to be easily educated. Individuals, beneficiaries, for example, often don't even recognize that if they're over the age of 50, they're at a markedly elevated risk of cancer. Individuals, adults over the age of 50, are at about 12 times the incidence of cancer as those under the age of 50, and it goes up very rapidly after the age of 50. So, a lot of education to do all the way around.
Yeah. And on the education, just making a plug for nursing here, as we think about a paradigm shift in where the point of care will be, involving nurses really early in the education and buy-in process is important.
Excellent. So a question from the audience. What is good enough screening detection when in some cases the predicate is nothing? How many false positive tests are tolerable?
Yeah, this is a question we've wrestled with, and you ask different people and you get different answers to that in terms of what their tolerance is. If you ask pancreatic cancer patients, who know the disease, they say, "Oh well, don't worry about that. You really have to find the cancer early. That's what's really important." But of course, there are many other considerations that need to go into that. I know kind of for our own work, we've figured maybe 10% would be acceptable, that would be a range that that in general would have a balance between the harm that it causes for that 1%, or for the harm it causes for that 10%, as opposed to the benefit that it causes for the 90%. That's so. Therefore, the 0.5% that we've heard today is well below that.
Maybe just, I've studied this question extensively, and we've done lots of advisory boards with regulators and doctors and experts in the field. And Lynn is exactly right. For single cancer screening, if you think about mammography or LDCT or stool-based colon, they accept a very high false positive rate, often around 10 or higher %, because they don't want to miss any cancer in the breast, and they're willing to tolerate those false positives. The consensus is largely in multi-cancer early detection. When you're looking for many, many cancers across many different organs, the false positive rate needs to be significantly lower than that. We've set as a bar for ourselves at Grail less than 1%. And you saw the stats from our latest validation, it's 0.5%. So we think that is the best way of minimizing harms, and that's the right approach for multi-cancer early detection tests when you're looking for many, many cancers. In terms of detection rates, it will be variable by cancer. But if we set the false positive rate at a very high bar, and you still find most of the lethal cancers, we think that's the right benefit risk trade-off.
Excellent. So, Josh, this may be a question for you. Is there any opportunity for this type of breakthrough multi-cancer early detection approach to detect other types of diseases as well?
Yeah, I mean, certainly there is potential for that. We know that these signals in the blood can arise from damage in tissues that are not related to cancer. Probably, we think there's potential in, this is well down the road, and others are looking at this as well, in cardiovascular disease, autoimmune disease, neurodegenerative disease. So there's an enormous amount of potential for looking at genomic signals in the blood for other diseases as well. We've seen, even in cancer, in hematologic malignancies, for example, where they have very strong signals in the blood, that we're able to detect even pre-malignant hematologic conditions by looking at these methylation patterns in the blood. So there's enormous untapped potential still. I think we're, now with a validated test, ready to get into early cancer detection. I think many other companies are still doing a lot of R&D in this area, and we'll learn a lot more over the next 3 to 5 years in conditions within cancer and beyond cancer.
Well, it certainly would be exciting if we have that potential to apply these methodologies to different disease states. Jody, go ahead if you had a comment there. Oh, okay. We may have addressed this question with the previous one, the false positives, but I'll read it in case anybody else has anything additional you'd like to add. What is a reasonable decrease in cancer-specific mortality across cancers for which there is currently no screening that the FDA should use as a potential metric of efficacy?
Well, I'll make a comment about it, and then other input would be welcome. Typically, the FDA is focused on clinical validation of this type of technology. And when you get into clinical utility, kind of long-term outcomes, they look at things like cancer-specific mortality reductions or shift in stage to earlier stages. When you're thinking about single cancers, they've been decades-long trials, often government-sponsored, to demonstrate those benefits. And they've taken 10 to 15 years to show. In fact, in some of the more recent studies, the mortality finding doesn't show up till year 15 or even year 20. So when you start thinking about how could you potentially assess that for 50 or more cancers, quickly it becomes not a feasible thing to do. And so, there are other ways of showing clinical utility by such as looking at a reduction in late stage cancer diagnoses. And you could show that in a large study. And I know GRAIL's doing that, and others are likely to try to establish that as well. But that takes several years of sequential testing. We have technology today that can find cancer in adults at elevated risk for cancer who have no idea they are walking around with cancer. And that's a technology we need to do everything we can to try to get into the hands of doctors today as soon as possible. And because, again, we are in a public health crisis with cancer. And so to wait 10 or 15 years for a government-sponsored mortality study would not be doing patients a service and or public health. So I think I would urge us to think, with innovative approaches to technological change like this, that we need innovative approaches to, as Anna mentioned, coverage policy, to regulatory policy, and to change clinical practice.
Yeah, I'll just add that that's the data behind how effective something is really. That stage shift data, the ability to change the stage at diagnosis, because the data is so strong about survival based on stage of disease, that seems to be a reasonable surrogate for actual mortality statistics as when you really try to design those studies. And that seems to be, the type of thing that, as Josh said, it's really critical that we do something soon, that we don't wait for those absolute endpoints, that we use some of these surrogate endpoints to get us where we really need to be much faster.
Great. Thank you, Josh and Lynn. So as the report notes, and I think was alluded to by several of the panelists, this is certainly an emerging global technology. In fact, the World Economic Forum identified liquid biopsy, or these kind of blood-based biopsy tests, as one of the 10 transformational technologies of the year 2020. And we've seen countries like China, which has made leadership in biotechnology part of their Made in China 2025 strategy. Competitor like Singular Genomics coming out of China, GeneCast out of South Korea. In other words, there's global competition for leadership in this field, both in terms of innovation of the technologies, but also in terms of uptake. I understand, for instance, that GRAIL's entered into an arrangement with the National Health Service in the UK to pilot the technology. So the question I want to ask here is, recognizing that cancer is a borderless global issue, can you talk more about kind of the global implications of MCED, and then kind of what the United States needs to do to set an example for the rest of the world as we promote kind of the uptake and adoption of these technologies?
I can start if you'd like. So, Stephen, you mentioned a really important concept here. Many countries have actually set goals for themselves around how to reduce late-stage cancer diagnoses. They've recognized, the UK is a great example, that too often cancer is detected in its late stage, and that's why cancer mortality is what it is today. And so in order to make a dent there, we need to find many cancers earlier. So some countries have really taken those steps and evaluated different technologies, and the UK is a good example where they've partnered with GRAIL in a very large way to try to provide this technology to patients in the national health system, the NHS in the UK. And so I think many other countries have set those types of goals for themselves. And I believe, and I know we've talked with Anna and many others, that the cancer detection rate in the population is something we need to be measuring. And we could do it by zip code, we could do it by state, we could do it by patient population, but we need to track that in this country. And we need to see that it's changing, that we're finding more cancer in the population. And then we also need to see at what stage are we finding them. And I believe we could set goals for ourselves very similarly to the way the UK did, to try to reduce late stage cancer diagnoses.
And just to add on to that, I think that the more, as you say, cancer knows no borders. And we have a lot to learn from how other health systems in other countries tackle the issue of cancer. And a lot of the research that's going to come from how other countries deal with their prevalence of cancer can help to inform us in the United States of what we need to do for our own population going forward. And a lot of that research will be used for the coverage determination process that CMS will undergo should this legislation be enacted.
And maybe there's one more point to add. There's a really virtuous cycle of innovation here, because therapeutic advances in cancer have been dramatic over the last decade, and they're going to continue to proliferate and increase. But they need early cancers to be detected in order for those trials to happen in earlier stage cancer, where you could use adjuvant and neoadjuvant treatments. And so there is potential that if we do make this paradigm shift to multi-cancer early detection, that we will dramatically improve the ability to do therapeutic clinical trials in earlier stage disease, which is what we need to do to complement what most early localized cancers can be cured and effectively treated with surgery and radiation. But adjuvant treatments in stage 3 cancers, neoadjuvant treatments are our future. And so I think there is a cycle of innovation here that's really important to recognize.
Yeah, and I do think part of the innovation will come in how a test like this could be used in a low and middle income countries, because that's going to be a drastically different approach than what we're looking at here and in Europe potentially, and how they use a test and what the journey looks like for patients. So I think that's another big change to come.
Absolutely. And we got 2 more questions. Maybe Josh, very quickly on the first one, there's a question of, can you describe what the path to FDA approval is?
Sure. I mean, this is kind of, again, groundbreaking innovation. The FDA's never reviewed multi-cancer early detection technology before. We're working closely with the agency. We're in a breakthrough designation with the FDA. It'll be a journey of producing evidence around its validation, its risk-benefit profile. And so numbers of studies are ongoing, and some are near completion. Others are starting that will contribute to our submission to the FDA. And obviously, we believe that when you're thinking about cancer detection at the population scale, at the in a public health way, we need real-world evidence at scale to be able to really demonstrate the population health benefits of multi-cancer early detection. And we're working with the FDA and others to try to make sure that we generate that real-world evidence at scale, so that we can demonstrate that we can find all these less common and sometimes rare cancers. And that just takes huge scale and numbers to generate those data. So it will be a process, but we think that the FDA has granted breakthrough designation, and we're working closely with them on how to get this done over the next couple of years.
Great, thanks. All right, let's close with this. President Biden has said that cancer will be a top priority for his administration, and there seems to be a broad bipartisan policymaker support for this effort, which is rare these days in Washington. What's your final message to those in Congress and to the administration about the opportunity that's at hand here? Welcome a comment from each of you as we close.
I'll start. I think the message is that we are at a place where we radically need our regulatory system to match the pace of innovation that we have for improving patients' lives and people's lives in this case. So I do hope we can move forward with the legislation on the Multi-Cancer Early Detection Coverage Act.
And I would just echo those comments as well and just say that this is an opportunity for Congress to remove an important barrier, and that barrier is coverage, and to allow CMS the flexibility to be able to decide, again, as new research is being conducted, CMS can change its coverage parameters, but that's really CMS's determination and not Congress's determination. What Congress can do right now is say, look, we are not going to stand in the way. We are not going to be a barrier. We are going to leave it up to the agency to decide their own parameters of coverage and hopefully be able to allow beneficiaries access to these innovative new treatments.
This is a real benefit of scientific research. I mean, our investment is paying off with this type of thing. Let's decrease the barriers and make it work for the American public and for those patients who need earlier detection.
And it's well recognized that we need to transition the U.S. healthcare system more broadly away from this break it and fix it healthcare system to one that's focused on prediction, prevention, and early detection. And if we can make that transition, healthcare will become more sustainable for this country. And we think early detection technology, like our multi-cancer early detection test, can be the test case for making that transition, from moving to a very, taking advantage of technology, helping modernize Medicare to the points made about providing these types of benefits to their beneficiaries, but also really moving the field forward and healthcare forward into this mindset of predicting, preventing, and detecting disease early.
Well, excellent. Well, thank you so much, Jody, Lynn, Anna, and Josh for joining us today. I think it's been a fascinating discussion about a revolutionary, breakthrough technology that has the tremendous opportunity to improve patient lives and, put America's response to the cancer challenge we confront on a more sustainable economic footing over the long term. I want to note that video of this event will be available online by early this afternoon on both the ITIF website and the ITIF YouTube page. So check it out there and forward it on to others who are interested. With that, thank you to our audience for joining us today. And a final thank you to Jody, Lynn, Josh, Anna, our all-star panel for your excellent remarks today. Thank you all.